Hello friends, we are from Government Medical College Calicut. We are going to discuss a case of fibroid uterus. Myself Dr. Jyothi Rameshchandran and with me is Professor.
I am Dr. Viniyachandran, Professor of Gynae, Government Medical College, Calicut, and we have got our own residents. They are going to present the case and
I am Dr. Amina, second year resident.
I'm Dr. Umur Salma, third year resident. I'm Dr. Jinu Jadev, third year resident.
So Amina is going to talk about the case.
Presenting the case of Nirmala, 47-year-old nulliparous lady. She is hailing from Malappuram. Her presenting complaint is heavy menstrual bleeding and difficulty in maturation for last 3 months. History of present illness. She was apparently asymptomatic till last 3 months. She developed heavy menstrual bleeding and she required 6 to 8 heavily soaked pads per day, and there is a history of passage of clothes.
so what is the reason why you are saying she is having heavy menstrual bleeding?
She's having increased number of pads per day, and there is history of passage of clothes, and she's having symptoms like easy fatigability and tiredness, and there is duration is about 14 days of duration of each cycles, and there is no history of dysmenorrhea, there is no history of intermenstrual bleeding. She's also having difficulty in maturation. She's having difficulty in initiation, and there is incomplete voiding of urine. There is no history of discharge per vaginum.
Any history of catheterization for difficulty in emptying the bladder? No such history.
There is no history of discharge per vaginum, no history of loss of appetite or loss of weight.
Retention of urine can occur in which type of fibroid?
Cervical fibroids.
Only for cervical fibroids?
Broad ligament fibroids.
Broad ligament fibroid? No. It's mainly
Some
for the
fibroids-
posterior wall fibroids, which will produce what will happen to the cervix in that situation.
So the uterus will be pushed forwards and it will come
Uterus
to
won't be pushed forward.
Cervix
cervix
will
will
be
be pushed
pushed
forward.
up so that it can produce wedging the uretrovesical angle, and it can produce retention.
Other type which is lying in the vagina, filling the vagina also can produce urinary retention.
And cervical fibroids also can produce. Why? Because it can produce pressure on the urethra itself. Okay. And also it can alter the UV angle depending upon whether it is anterior, posterior or central. Okay.
Menstrual history. She attained menarche at 14 years of age. She is having regular cycles, no history of dysmenorrhea. She developed heavy menstrual bleeding for the last 3 cycles. Her last menstrual period is on March 1st. Marital history. She is an unmarried. Past history, no history of any surgery, no history of any thyroid disease. She is not a case of hypertension or diabetes.
Why do you want to ask for the hypertension?
There is increased chance for fibroid in hypertensive
It
patients.
is said that around 10 millimeters of rise in the diastolic pressure can increase a 10% chance for development of fibroids. So,
Family history. She had a cousin with similar complaints and undergone hysterectomy. Personal history.
so family history is also important because it can run in families, especially if the first degree relative having fibroid. Okay.
Personal history. Sleep and appetite is normal. She is having normal bowel movements. She is complaining of difficulty in maturation during the last 3 months of duration. Socioeconomic history. She is coming from a middle class family. General examination.
Anything else in the history? You said she has got heavy menstrual bleeding and bladder complaints, isn't it? Any other complaints she can have? No, she may come with abdominal distension, and also she can have pressure symptoms on the legs. She can come with edema, varicose veins. Okay.
Is she having edema? So these are all pressure symptoms.
General examination. She is moderately built and nourished. Her BMI is 23. Pallor present.
So, what about BMI and
Obese patients, there is increased chance for fibroid.
Why?
Due to peripheral conversion of androgens to estrogen, and fibroid is a estrogen
The
dependent
peripheral conversion in the adipose tissue to the estrogen, and another converting by peripheral conversion, and then hyperinsulinism, which produces fibroids. Yes.
Pallor present, no cyanosis, clubbing, lymph node enlargement, bilateral pedal edema present. She is having thyroid enlargement. Breast skull spine normal, no varicose veins.
Did you see the breast for any secretions? Huh? Should you see? Yes. Can there be galactoria in fibroids?
Local hyperprolactinemia.
Yes. Local hyperprolactinemia can produce galactoria. So you have to examine the breast for that.
So in the general examination, we have to look for one more thing, that is cutaneous
Cutaneous manifestations of
fibroid, that is
fibroid.
cutaneous leiomyoma. It is seen in what
Reed
condition?
syndrome.
Reed syndrome. Yes, Reed syndrome is cutaneous
Multiple
fibroids,
cutaneous fibroids and uterine
fibromas
fibroids.
and fibroids. Okay. It is an autosomal. It's an autosomal dominant condition. Okay.
System examination, cardiovascular system, respiratory system with the normal limits. Lower abdomen distended, all quadrants of abdomen moving equally with respiration, hyperpinguination on the left iliac fossa, no scars or sinuses, no visible pulsations, no dilated veins, hernial orifice is normal. On palpation, there is no local rise of
And also you
temperature.
have said there is no
Basically, no
pulsation.
pulsations.
Okay. Okay. The transmitted pulsation you are not seeing. Okay.
On palpation, there is no local rise of temperature or tenderness. A mass of firm hard to mass felt in the midline, mainly in the midline, extending to both iliac fossa and umbilical region, which is smooth surface, and all borders are palpable.
So it is in the umbilical region,
Which are the
hypogastrium,
regions?
iliac, and so
So
it is almost filling the
filling
lower
the
abdomen.
lower
Okay.
abdomen.
Can you reach below the mass?
Lower border is not palpable.
You palpate all the
Borders.
Lower border is not palpable.
not palpable. Then
And regarding the
so
mobility,
you are getting the upper border and the
Lateral
lateral border.
border.
Lower border is not palpable. And then what is the size?
around 30 weeks of gravid uterus.
So you can say either in the weeks of gravid uterus, or you can say in centimeters. That is vertical as well as transverse.
It has got restricted mobility.
But
No.
transversely you can move the mass.
Only a little,
What about up and down?
not mobile.
So when the mass is of huge size, you cannot expect it to move. It may not be having mobility because of the size of the mass. Okay.
Auscultation, vowel sounds present, no audible bruit. On percussion, there is dull note over the mass. Heard over
Why it is dull?
because it is a solid mass.
And what happens to the intestines?
Intestines are pushed
They are
aside.
pushed to the sides.
Sides.
That's why it is dull on percussion.
Is there any evidence of ascites? It's a huge mass, is it not?
There is no aside.
How will you elicit it?
From percuss from the midline to the flanks.
That is, you are looking for the shifting dullness.
Shifting
is it not?
dullness.
Okay. Then you said it's a smooth mass of 30 week size. Are you getting fetal parts? Are you sure? Yes. So you have, because a patient may say that I am having regular cycles. She may come with pregnancy, and you open up and you see that pregnant uterus. Anyway, you are going to do other investigation as well. Even then, so all clinical cases you have to exclude pregnancy, especially.
Now we go for the local examination.
Local examination, labia majora, minora, appropriate for age. Now,
That's not even say appropriate position. So you can say it's normal or abnormal. That's not. If it's normal, normal. If it's abnormal, what abnormal you will say?
local examination, labia majora, minora, normal, perineum normal. Speculum examination, cervix.
Could introduce the speculum in unmarried patient. Because hymen was torn. Could use a speculum. Okay, if you could use, you say.
Cervix was thinned out, mass was protruding through the os. Cervix was actually
She doesn't have any history of any chronic discharge PV, blood stain discharge PV, with mass protruding out of the cervix.
How is the interventional bleeding?
no history.
Okay. So cervix is thinned out and a mass is protruding in the vagina. What is the size of the mass?
So this is around 4 into 3 centimeters.
4 into 3 centimeters. What else characteristic of that mass which is protruding?
Mass was firm in consistency and not bleeding on touch.
Is it
Non-tender,
necrotic?
non-tender,
Is it
non-necrotic.
Was there any discharge
Foul
with that
smelling
mass?
discharge.
Foul smelling discharge?
No false smelling
No
discharge.
foul smelling discharge.
So, what are the possibilities if you are seeing a mass
In the vagina.
vagina?
Could be cervical polyp.
Okay.
Could be chronic
Inversion. Or it can be.
Fibroid polyps.
So you have to differentiate between the two, chronic inversion and fibroid. How will you differentiate? Maybe just by doing inspection.
You have to combine it with biomedical examination or use a sound to differentiate between polyp and inversion.
So if it's an inversion, you won't be able to negotiate the sound. Okay.
What else?
Vaginal pelvic examination, uterus enlarged to around 30 week size, which is non-tender. There is transmitted mobility present.
So you have to say, first of all, cervix and the mass you said, and then you are going for the bimanual pelvic examination. Bimanual pelvic examination, you have to say whether the uterus is palpable or not. That uterus is normal or abnormal. If it is abnormal, what is abnormal? If it is normal, whether it's normal, it's normal. Then it's finished. Whether it's abnormal, it can be low in size or small in size, or it can be large in size. If it's large in size, you'll have to say whether it is a uniform enlargement or irregular enlargement. Then you'll have to say other at next answer.
The cervix is thinned out with a mass of
So it's like taken up.
Taken.
It's like taken up cervix. Okay.
and the uterus is irregularly enlarged to 30 week size, and it is non-tender, and there is no adnexal mass, and there is transmitted mobility present.
Since the patient is having urinary complaints, would you feel that there is a fibroid in the anterior wall of the uterus which may be compressing the UV angle? Is it like that?
It's not very differentiated mass which is huge in size, 30 week size, irregular mass.
Is it irregular?
Irregular.
So there is no bossing anteriorly.
And how you elicit transmitted mobility? See, the main problem here in this case is 30 week size, 32 week size mass. If you may not be able to elicit transmitted mobility because you have sufficient space to push up the swelling so that the cervix also moves with along it. If when a mass is huge, you won't be able to elicit that. If the mass is of average size, you will be able to do that for small size. Okay.
Just summarize your case.
This 47-year-old nulliparous lady.
So here this is important is age of the patient, parity of the patient.
She's having complaints of heavy menstrual bleeding
Yes.
and
So the
defecating
importance is age of the patient, parity of the patient, and her main complaint, because you have to address the main complaint of the patient. Otherwise, you will treat the patient and her main complaint will continue. Okay.
She's having heavy menstrual bleeding and defecating intrusion for last 3 months. There is no significant past history, family history of fibroid uterus present. On general examination, she is pale with bilateral pedal edema. On abdominal examination, fibroid uterus of 30 weeks gravid.
There is a mass of 30 weeks.
We will come to the diagnosis after all the examination.
There is a mass of 30 week size in the abdomen, which is regular, firm to hard in consistency, and all borders palpable except the lower border, and the mass has got restricted mobility. On perspective examination, there was a mass of 3 to 4 centimeter protruding through the os and cervix.
Polypoidal mass.
Polypoidal mass, and cervix was taken up. By
Cervix felt all around the mass.
All around the mass. In bimanual pelvic examination, cervix thinned out, and there was the same mass felt, and the uterus irregularly enlarged to 30 weeks size, 30 week size, and bilateral adnexal normal.
Cannot make out with such a big mass. Cannot feel the adnexal separate.
So everything is filling the pelvis as well as the abdomen. So it's a 2H mass. Yes,
So
your
diagnosis is
clinical diagnosis.
It is fibroid uterus.
So what are the points in favor of fibroid uterus?
Fibroid uterus, the patient, first the patient is Nandi Paris.
Yes.
Age.
47 years old. She's in
So,
Nandi Paris.
as age increases, the incidence of fibroid yes. After menopause it may decrease, but otherwise it is increasing. It's not. It has one is age of patient,
Patient has
nulliparity,
family history.
family history of fibroid is there.
She's having complaints of heavy
Heavy
menstrual
menstrual
having menstrual complaints.
What is the reason for the heavy menstrual bleeding in case of fibroid?
Fibroid uterus is due to the submucosal fibroids which increased vascular area.
Only subcutaneous fibroid?
Or
You can answer.
Increase vascularity, increase surface area, and submucosal fibroid. And there is dilated veins over the fibroid which can bleed, and increase endometrial thickness which can also cause bleeding in fibroids.
There are so many reasons why a patient can have increased bleeding in case of fibroid. One is increase in the surface area. So when the fibroid is there, there is increase in the surface area. So naturally, large surface has to bleed. So that's one reason. Another most important reason is the presence of venular ectasia. Venular ectasia is produced as a result of pressure effect. So pressure effect on the venous drainage, producing dilatation of the venules on the surface, which can go for rupture. Okay, so it produces bleeding. Especially it can produce submucous fibroid, it can produce intermenstrual bleeding as well. Then, no, then the uterine contractility is also affected, so it can produce bleeding. Then, it is a hyperestonic condition, so it can have hyperplasia, so she can have excessive bleeding. Then,
disparity between the coagulative and anticoagulative mechanisms.
then another most important is the ratio of prostacyclins versus
Prostacyclins are more than
thromboxanes order,
thromboxane.
so which will again in favor of
Bleeding.
dilating, also dilating prostacyclin. Naturally, she can have excessive bleeding. These are the reasons why she can have excessive bleeding. Okay. Then, any other symptom fibroid can have?
Pressure
Pressure symptoms. So,
So where all can the pressure symptom manifest?
It can be manifested in legs with pedal edema.
Yes, which is this patient having? Do you know?
It can result in a hydronephrotic nephrosis if it is pressing upon the urine.
that patient will not give any symptoms.
Then there is she can present this constipation, urinary retention, or incomplete evacuation.
Recurrent UTI.
Or she can have frequent symmetry, especially if an annual fibroid pressing up on the dome of the bladder. It can irritate the bladder and can produce frequency. Okay, so any symptoms can have. Then, any other?
What are the symptoms?
Especially
So
it is spasmodic.
unbalanced, you can have subfertility. So why it causes subfertility?
Uterine and ovarian causes are there. Uterine causes due to defective implantation.
No. See,
Infertility.
biologically,
It is regular
The
proportion.
sperm, in the cervical fibroid, the sperms will be
the regular fibroid, see, depending upon the
Location.
location of the fibroid, it may alter the position of the cervix. So the cervix may not be.
This is a final pool.
Yes. So it can produce one. Then increase in the size. So transport mechanism may be altered. Then it can produce the hormone is blocked. And also if it is a subserous fibroid, it can alter the tubo ovarian anatomy. That can produce infertility. And also it produces abnormality in the endometrium. So endometrial abnormality is biochemical as well as cytokines. All these can be altered because of the fibroid. This can lead on to yes, difficulty bandage.
Associated salpingitis, 15% may be associated.
And also any other reason? You only said patient has got hyperestonism. What will produce hyperestonism? Anovulation. So anovulation may be another reason why she is subfertile. Okay. So per se, what is the chance of any female getting fibroid during her lifespan?
Incidence of fibroid.
So around 70% is the chance for getting fibroid in the lifespan of a female. And what about any racial difference?
Second, bags are more prone for fibroid than the fibroid.
Right. Why? So, this is said to be one reason is vitamin D deficiency because guys have got deficiency in conversion of the vitamin to active form in the bags. So that may be the reason why it may be having increased incidence of fibroid. Then, and apart from that, any other?
It can be asymptomatic. 50%
Yes,
of the
that's
fibroid
most
is
important.
asymptomatic.
The fibroid.
So sometimes you can just discover when the patient is coming for some other complaints.
So, yes, around more than 50% or around 50% may be asymptomatic. So, in such patients, that's the reason why we said we have to address the symptom. Okay. So, how will you confirm your diagnosis?
You can go for an ultrasound. Since it is a huge mass, a transabdominal ultrasound can visualize the fibroid and can differentiate it from other mass.
Yes, definitely. In this case, you have to go for transabdominal as well as transvaginal. You said a polyp is there, so you have to find out
Origin.
Yes, origin of the mass. And what are the ultrasound findings in case of
How does
fibroid
fibroid
uterus?
look in ultrasound?
Fibroid, it will be having a well-defined lesion.
May or may not.
Either it can be either hypoecogenic or hyperecogenic or isoecogenic, depending upon what? Depending upon degeneration, and depending upon the content of the fat, also as well as yes, as well as the fluids inside, and depending upon the amount of biometric content as well as fibrous content. It depends upon that it will produce difference in the ecogenic pattern in the real time.
Any association with any other condition? Will ultrasound suffice in your patient?
MRI has to be done to correct mapping of the fibroid.
Are you planning a myomectomy for her?
She's signaled by us.
Yes,
So why-
can you go for this patient for myomectomy?
Huge
No.
mass is
Whether it is huge large, she
It's
can
not the
undergo
criteria.
myomectomy. Why? Because she is nullified.
nullified.
Suppose she wants, she can go for IVF. It's not. Even if she is 40, depending upon the AM's level, she may have ovum reserve, and then you can go for IVF. Okay.
So if you want to do a myomectomy, definitely mapping has to be done. It's better done with the MRI. So what will MRI help you in finding out?
MRI will differentiate if we have doubt in case of adenomyosis, we can differentiate
That's the most important thing because you have to differentiate between adenomyoma and a fibroid, especially if it's a single mass, because it will be difficult to treat adenomyoma when you are going for myomectomy.
Any other organ you want to see on ultrasound?
We have to look for hydronephrosis, kidneys.
For what? Because of the back pressure effects, okay, on the ureters as well as the dialysis system.
And suppose the ureters are dilated, then
Should be having hydronephrosis.
so how will it affect your management?
There is increased chance for uterine injury during surgery.
So you can plan clean
There are two schools of thought regarding stenting. One, and especially here in this case, stenting may be useful because you said a huge mass in the cervix and cervix is effaced.
There are illuminated stents also which can be seen during surgery.
Okay, when the cervix is effaced and large, especially cervical fibroid, the chance of injuring the why?
Anatomy is already disturbed and ureter is only 1.5 centimeters away from
Yes, it's
cervix.
close to the cervix. So if you want to clamp it, if the cervix is effaced, you are clamping laterally. Naturally, it will endanger the ureters. So that's the reason why you have to look for the force of the ureter. Or you can delineate the ureter early and then open.
Can you suspect leiomyosarcoma in your patient? When do you suspect that this could be a leiomyosarcoma?
Leiomyosarcoma occurs in advanced stage, and the is
Patients 47. So what characteristics will help with
rapid
size?
pain,
excessive bleeding, and
massive touches.
And what about the ultrasound or the MRI?
Increased
Use a Doppler.
So you
increased
give,
vascularity.
you see the vascularity.
Otherwise, the center of the fibroid will be vascular and normal fibroid, whereas it will be vascular with RI and VI increased.
So because of what is the reason for the increase in RI and VI? Because of the angiogenesis. Because altered angiogenesis will produce increased vascularity. And increased vascularity, that doesn't say that she may be having a sarcoma. Only by histopathology you can confirm it. But ultrasound as well as MRI will help you say that you can suspect with the history as well. It may be a case of EMI. What are the causes of pain in fibroid? You mentioned regarding pain.
And torsion, hemorrhage, infection, and also leiomyosarcoma.
Dysmenorrhea is one pain. Dysmenorrhea is pain. So all these can produce pain. Okay. So pain can be there. Okay. When you suspect that increase in the size as well as pain, then you will be suspicious that it is the case of leiomyosarcoma. Then, how you are going to manage this patient?
Since the patient is having symptoms, she needs to be corrected. After explaining her about the management, like surgical and medical management.
For this patient, there is no question of medical management.
Preoperative
patient has to go to
investigations,
surgical
anemia. Preoperative investigations, anemia has to be corrected, and she's having a thyroid enlargement. Have to do
You look for any
functions.
comorbidities you corrected. Okay, fine. Then,
She's nulliparous and she may need a future fertility preserve. So
you have to counsel the
Counsel,
patient.
and
Counsel the
then
patient
decide.
regarding what are the treatment options you have. What treatment options you put forward with this patient?
myomectomy or
Okay.
hysterectomy.
She's married.
Married.
So till now she would not marry. She thinks of marrying. She thinks of marrying then.
So, you said you are going for myomectomy or hysterectomy. And you have to tell with the patient, patient is having heavy menstrual bleedings and all. And we are going to myomectomy. You are going to tell to the patient that you are going to completely cure with your myomectomy.
How
That's-
many percentage patients can have anorexia even after myomectomy? 30%.
Yes. What is the reason for persistence of anorexia or heavy menstrual bleeding in case of fibroid after myomectomy?
Unrecognized myomas.
No. That you are going to mark it and then you are going to myomectomy. See, there is always myohyperplasia which is going to return
Not
back.
get reversed.
So that patient can have a continuation of heavy menstrual bleeding. So that is the reason why you have to tell the patient that patients you may end up with continuation of the same symptom. But since you want to preserve the uterus, we are doing the procedure. Okay. Then myomectomy, then hysterectomy. So if you are going for hysterectomy, it's a definitive treatment. Patient will be totally asymptomatic. That is 100% sure that patient is going to be asymptomatic. Okay, but she will lose the future fertility. Okay, that's it. Then,
Then we can
So you're planning out?
myomectomy.
You can't go for uterine embolization for your patients.
so
no?
uterine embolization is not indicated in case
Your
of
patient.
patient is future,
Fertility.
yes, fertility preserving patients. So in such situation,
And
you are
also
not.
when there is submucous fibroid.
So,
So you don't do it. What are the contraindications for uterine embolization?
Uterine embolization contraindicated childbearing.
The
issues,
patient wants
preserved
childbearing.
children,
Okay,
wants
then?
childbearing, active infections.
so what is the reason why it is contraindicated?
Embolization can cause necrosis of the endometrium.
Oh, no.
Or
Premature
ovarian, premature
Premature
ovarian
ovarian
failure.
failure, intrauterine adhesions.
And it can produce intrauterine adhesions in androgen also it can produce uterine necrosis as well. So she may not conceive. Apart from dysfunction, patient can have ovulatory dysfunction, can have premature ovulation, premature ovarian failure, and also she can have amenorrhea, then abortions, then she can have abnormal placentation, she can have preterm labor, and rapid growth restriction as well. So all these complications can occur after.
So in your patient, uterine artery is out of question because she is having a submucous myoma. Any other condition you don't want to do? There is a pedunculated fibroid. What is going to happen after doing? Yes, it will extrude out, and that may get separated and grow as a parasitic fibroid. But only thing is your patient is perimenopausal. That is the only advantage of UAE, but you cannot. And the size, such a big size, and doing the surgery and all will be difficult. So that is out of question.
What material are you using? It's polyvinyl for particles of size. It's around 500 to 710 microns. Okay, you are taking both sides.
Then is your patient available for MRI, FUGS?
The size of the fibroid.
Yes, size. So, feasible.
So, in which of patients you won't do mass FUGs?
It is more than 10
10 centimeters.
centimeters.
Apart from that, when it's focused, you are focusing the ultrasound, and the focusing ultrasound area is more than 50% outside, then you won't go. And also, if there are more than 6 fibroids of size more than 4 centimeters, then also you won't proceed with. And also, if the distance between the abdominal wall and the mass should be around 12 centimeters. So more than then also you are not going to succeed. And one of the complications with FUGs, one is pain, especially for the nerve roots. What is the reason for pain for the nerve roots after FUGs? It is because if it is an ultrasound, it is better absorbed onto the bone. So once it is absorbed to the bone, it will produce heat. Once heat is produced, the nerves are over it. It can produce nerve damage. That is the reason why. So it has to be at least 4 centimeters from the bone. Then only you will do the MRI. Okay.
So what is the ideal management for your patient?
Hysterectomy in this patient is
Will it be an easy hysterectomy? What problems you anticipate?
injury.
Uterine injury. Why?
This is a cervical fibroid and it distorts the anatomy and it can cause uterine injury.
So what precautions will you take on surgery?
So it's possible is to restore the anatomy after manipulating the fibroid so that the clamping.
Which clamps you should restore the anatomy? For putting which clamps?
Uterine clamps
and
also
parametria. So how will you tackle the fibroid which is in the vagina?
cutting off from the uterus. Cervical fibroid.
Bisect the uterus.
Bisect the
Bisect the
and
uterus
divide
and
the
then
pedicle and
cut the pedicle and
push the uterus
down.
push the fibroid down.
Meanwhile, you can hold that polyp with a pulsellum and somebody can just pull it out and then you can
So you
proceed
have
to
to
hysterectomy.
pull the fibroid with the valsalum earlier. And
Apply the
wait.
valsalum and keep.
And then you cut it, bisect the uterus, cut the pedicle, and ask the assistant to pull it out.
Pull it out.
Okay, so you can reduce the width of the cervix. By that you can produce a normal size cervix, and then you can put the parameter clamps. Then,
Myomectomy.
so suppose let's say which fibroid, cervical fibroid, you want to do the myomectomy. In that case,
Intracapsular dissection.
see that's whenever you are going to myomectomy, there are certain principles. What is you have to reduce the blood loss. How you can reduce the blood loss, especially if you are with a frontal fibroid or body of the uterus.
Preoperatively, GNRC agonist can be tried in order to reduce the vascularity and also
So, what
size.
is the disadvantage?
It is of high cost and it can result in vasomotor symptoms and also
Loss of plane.
nose playing.
The main reason is if you produce degeneration of fibroid. Once it produces a degeneration fibroid, you won't get a proper
Plane
plane
or dissection.
for the dissection. As well as small fibroids will
disappear.
be missed.
Even
So,
after
yeah, after myomectomy, what is the chance of recurrence of fibroid?
30%.
Yes, there is around 20% of chance of recurrence of fibroid. So, in what situation you can say that this is likely to be go for recurrence? If the size of the fibroid is very big, it is a large fibroid, and also the residual tissue is more, and also if there are multiple fibroids, in such situations, she is likely to develop recurrence. In such situation, you can tell that it can happen. Okay, then.
So principles of myomectomy.
we can use either vasopressin.
First is to decrease blood loss.
First.
Second is to be intracapsular. So decrease blood loss, what do you do?
And we can use vasopressin
No,
injection.
before that.
Preoperatively change.
Yes, preoperatively.
Pre-ovulatory.
Immediately after the
When
period.
should you do?
Yes.
Should you do the procedure? You do it post-menstrual.
Post-menstrually. And then you can use
During surgery, what
during
do you
surgery,
do?
injection vasopressin can be.
How much?
It is 20%. It is 1 ampule contains 20 ml. It can be diluted in 100 ml in a
1 ampule is 20 units.
20 units and can be diluted in 100 ml and 20 ml can be taken. And
It is 10 units, 100 ml. 20 units, 200 ml.
Okay, you take it and then you inject. Where will you inject it?
at the site where you are putting the incision.
No, you
At
have
the
to
junction.
inject to the normal myometrium. So you inject it to the normal myometrium, and after injection you will have to withdraw and see it is not intravascular. That's the most important thing. If it was intravascular, what will happen?
Can sudden bradycardia, hypotension.
Then bradycardia or cardiac arrest and the problems of it. So you should not inject into the intravascular. Okay. Then
Then we can use.
this is a physiological mechanism by producing vasoconstriction and you are reducing the blood loss. And other one is
The myomectomy clamps can be used.
that's mechanical. So you can use myomectomy clamps, or you can use tourniquets,
Tourniquets around the uterine artery.
or you can use uterine artery temporary occlusion,
Occlusions.
and then you can do surgery. So these are the various methods by which you can reduce the blood flow. Okay, so if you are going for a myomectomy, where will you put the incision?
Better to put an incision in the anterior of the uterus.
Suppose the fibroid is on the posterior wall.
The posterior wall incisions can result in
And the main problem is wherever is the fibroid, either fibroid is anterior or posterior, you can put the incision on the most prominent part of the fibroid. Okay, so previously one used to say that even if the fibroid is in the posterior wall, you put an incision on the anterior and then cut through the cavity and then enter the cavity, then enter the posterior wall and then enucleate it. But it is not needed now because of the advent of laparoscopic myomectomy, they are putting incision on most prominent part of the fibroid after giving vasopressin, and then it can be either vertical or transverse. The advantage of vertical, they are saying that bleeding will be less, but disadvantage is you are cutting all the vessels because all the vessels are coming from the sides to the center. Whereas if you are putting a transverse incision, the one or two vessels will be affected. So you can put either vertical or transverse. Important thing is you have to enucleate the fibroid and then absolute hemostasis and closing the bed. So you can have to close the bed by what sutures? Now you have to close the bed either by circular bursting sutures, or you can use pair of 8 sutures, or you can use vertical mattress, or you can use transverse mattress, but you will have to obliterate the bed. Otherwise it will produce a hematoma there and it will produce swells, healing and killing by fibrosis, and it will produce a weak scar.
Have you heard of baseball sutures? What is the advantage of that?
Better hemostasis.
No.
Advantage is there is no suture material on the surface. So
So-
because of that, there won't be adhesion formation.
So that is in baseball, minimal suture material will be seen on the surface. So that's the advantage of it. Any other method of suturing you can do apart from baseball? we can use neuromuscular suturing. No suture will be there on the surface. That's what we are doing now. Instead of baseball, we are doing neuromuscular, just like subcutaneous. So there won't be any suture material on the surface. You will have to have adequate hemostasis, proper approximation, and minimal suture material on the surface. So that's the dictum for myomectomy. Okay, done. So after myomectomy, how many myomas we can remove?
As many.
So you can remove as many as possible. Only thing is you will have to leave behind a normal uterus. Okay, so
So when you're doing a laparoscopic myomectomy and you have multiple myomas, what are the problems that can happen? Myomas will get lost. So what will you do about that? Yes, you can use a bag or you can use a thread, and you can just thread it just like beads. You can thread all of them together so that you don't miss them. If you miss them, then what is going to happen? They can develop in the peritoneum, and that is called
Yes, parasitic
leiomyomatosis in the pectoral cavity can happen.
Peritoneal leiomyomatosis. So it can produce. So if you are doing myomectomy with laparoscope, you have to remove it in. How will you remove it? You will have to remove it. Morcellation. Morcellation should be inside the bag. That's it. Endo bag, morcellation, and removal of the fibroid.
Any other method of removing it? Any other route?
Yes,
Calicut.
And remove the fibroid. So you can remove any number of fibroid anterior position. Only thing is, if you are entering the cavity, what precaution you have to take?
The cavity is open while removing the fibroid.
Suturing should be appropriate.
The only thing is, if the cavity is entered, you will have to look into the cavity and see whether there is any some polyps, etc. So you can remove it. And also, after that, you will have to close the cavity.
Meticulously close the cavity so that you do not produce an nitrogenic tubal blockage, specifically when it is in the tubal area, cornal area.
Okay, then you do the myomectomy. After that, you will have to clean the peritoneal cavity, then close the abdomen. Okay, then fine.
Supposing you've opened the cavity, should you do hysteroscopy later on?
She's presenting with any symptoms?
No. Ideally, you should do a hysteroscopy because if you open the cavity, there is chance for intrauterine adhesions. So you should do a hysteroscopy and break those adhesions after surgery. What about now medical method of management of fibroid? What are the drugs used?
GNRH analogue can be used.
No. So what are the drugs you said? The main symptom.
Symptomatic
Yes.
management with NSAIDs and tranexamic acid
Yeah,
and
you-
antifibrinogen.
Bleeding is there, then you can use
Yes.
NSAIDs.
What about the dose? When do you want to give? When do you want to give? Every day?
During the period.
First few days in her flow.
Start with the period. Day 1 you have to start and then continue it for 5 or 7 days. Okay.
Then what else?
Tranexamic acid can be used. Then GNRH analogue can be used.
No.
What about the
I have
last?
seen how many
Sorry.
patients you are giving.
Mifepristone.
Yes,
No.
there are other drugs.
See, when a patient is having heavy menstrual bleeding, you can use this non-hemostatic agents, that is tranexamic acid, etc. Apart from that, you are giving progesterone. It's not hemostatic progesterone you are giving. It can be metotrexate or norethindrone acetate. You can give.
You can give oral
Also
contraceptives.
Yes.
They also decrease the size of the fibroids. Then
Mifepristone 10 or 25 milligram only for 3 months can be given.
how does it work?
It is anti-progesterone. It has antagonistic action on the endometrium, and it will reduce the size of the fibroid.
Endometrium is acting on the
In
endometrium.
the fibroid, it will act on the receptors on the fibroid.
receptors on the fibroid.
It will reduce the mass.
It is an anti-progesterone agent. Okay, so it produces decrease in the progesterone receptor activity, and then it can produce decrease in the size of the fibroid. Any other drug?
Ulipristal acetate.
Ulipristal acetate. What is the dose?
5
5 milligram daily. You can give how long?
3 months.
You can give 3 months, 5 months, 6 months. After 12 months, they have
What
to
should
give
you monitor before giving this drug?
Endometrial thickness.
No. You have
It has got toxicity to
liver toxicity. You have
liver. So whenever
Left
patient is before starting, do a liver function test. And after 1 month, you have to repeat and see whether it's toxicity developing.
But the mechanism of action of electrolysis acetate.
Selective progesterone receptor modulator.
It says selective progesterone receptor modulator. How does it function? How it functions? It decreases cell proliferation. One. Then it increases the apoptosis and it decreases the angiogenesis by inhibiting the vascular endothelial growth factors. Okay. So by these mechanisms, it curtails the growth of the fibroid, and so you can continue it. It has got a hypothalamo-ovarian axis inhibition also, and it has got an anti-progesterone action. So endometrial proliferation can occur. So if your patient is having amenorrhea, patient can develop amenorrhea because of that. And if endometrial thickness is high, you will have to take a biopsy as well. And then you will have to specifically mention that this patient is on such and such drug. Otherwise, they will report it as case of endometrial carcinoma even. So you can use levodopa acetate. Then any other drug? Yes, other drugs you can go.
Dinosaur.
Dinosaur is not used.
Letrozone.
Aromatase.
It has got androgenic side effects on higher dose, so that's why it is not used.
Yes,
Yeah.
LNG IUS can be used.
But
Only thing is
uterine cavity should not be destroyed.
regular cavity. So if cavity is abnormal, the chance for expression is high.
And then, as you said, GNR is
So
So,
if the-
but what about this, the recurrence after stopping these drugs?
After stopping, GNRs are allowed after stopping. The chance of recurrence is very high.
Yeah, 47%. Whereas with mifepristone it is 88%. So that is the advantage of mifepristone.
And so how long you give GNRs alone?
If it is used for more than 6 months, add-back therapy has to be
added. If it's
Should
even more
start
than
add
6.
back therapy after giving the GNR channel.
after 3 months.
Why? Yes, after 3 months. Why?
1 to 3 months. Why?
To get the action.
If you are giving GNRS, the mechanism is by producing apoptosis. And if you are giving a drug which is favoring cell proliferation, it has got a counter effect. So you should not give that. So once the apoptosis starts, then you give GNRS in the lower dose. Add back progesterone.
And what do you give as add back?
Tibolone can hold.
Cloxacillin. Without NCC.
Mainly given is progesterone acetate. So you can give even combination with estrogen as well.
Estrogen you can combine.
So these are the drugs often used. Then there are other drugs like aromatase inhibitors. Then
What about GnRH agonist, other
Antagonist.
antagonists.
What about the others? Like
Leuprolide.
Leuprolide. What is the dose?
Leuprolide is 3.75 milligram subcutaneous injection, monthly injection.
Then,
Gaucil, Naphil.
how do you give them?
They
Naproxen
also give
is
you
a spray.
nasal sprays are
Spray
available.
200 milligram, and you have to give it in the morning and in the evening, or on a single day.
But the main problem is that you will have to use it regularly. But the other one is depot preparation you can give monthly. Then any other drug? Somatostatin analogs also can be tried. These are the various drugs which is often used in case of fibroid. Then
And then we have not touched upon hysteroscopy. So what are the indication in which types of fibroid you do hysteroscopy? And
0 and 1 and 1.
yes, 0, 1 and almost 2. So the size should be
Less than 4 centimeters.
and sometimes you may have to go for repeated procedure. What is the main problem with hysteroscopy?
depends on the medium you are using, no? So
It will produce what?
Hypovolemia.
Hypovolemia.
Hypo.
Hyponatremia.
It produces
Hypervolemia and hyponatremia.
So it can produce cerebral edema, pulmonary edema, all the so you have to stop the procedure when there is a deficit of more than 1500 ml. Okay. So now newer methods are available. That is, we are using isotonic
Yes.
saline, where bipolar current can be used, and also
You can use scissors.
mechanical methods. That's mechanical modulators are available, which doesn't have any current use, so that it can be used in any medium.
Have you heard of hydrostatic massage? So supposing the fibroid is not jetting out, you just cut the capsule and then you decrease the pressure. So this fibroid will be projecting out. So you can control the inflow outflow, the pressure of the uterine pressure, so that the fibroid projects out and you can do it. Hydrostatic massage.
So you remove the fibroid. Will you put any IUD device or estrogen after
Yes.
removal?
Should
No. At present, nobody is
It is
doing
not
it.
recommended.
Not recommended. So these are the various methods by which we can treat a case of fibroid. So the treatment depends upon the age of the patient, priority of the patient, wish of the patient, as well as the symptoms of the patient. Okay, so depending upon that, we treat the patient.
So we must thank the postgraduates for the good discussion.